and I manage the teaching and research project side. So among those is the Research Your Path series. And what this is just a series of interesting and educational talks on current research in various different fields and what their future research initiatives might involve. This series is also interactive in that we provide teaching opportunities for students to apply to, and that they can give talks themselves in their interested field as a way of gaining teaching experience to boost your CV and also gain points for medical portfolios. Speaking of which, we do have an opportunity for a cardiac research talk on kinase signaling and heart failure with Dr. Oshiendi. If you're interested in this, you can check out our social media, which will have all the links in our bio. Additionally, a feedback email will be sent out after the talk, which will provide links to all of our opportunities as well. On the research side of things, we have an exciting opportunity for students to be part of critical care medicine project. This will be on clinical informatics in critical care and how they contribute to research and innovation with Dr. Wilson at the Manchester Royal Infirmary. These roles will involve data collection, organization, analysis, and coordinating clinical studies if needed. The project is fairly flexible in that Dr. Wilson is willing to talk to various students about what they're interested in and how they'd like to contribute to the project. At the end, you can be guaranteed your name being on the paper as a published author, or you can be given an opportunity to present findings via an oral presentation during a conference, or you can even take part in an audit. If you're interested in any of these things, please check out our social media for links to apply. Additionally, again, the feedback email will provide you with all the links after you complete the feedback form. So that's all from me now. Thank you very much for coming, and I'll hand you over to Asta, who will provide you with all the links after you can, who will introduce your speakers for you.
Hi everyone. Dr. Dalia Tsimpida is a chartered psychologist and a postdoctoral public health researcher, teaching communication skills to medical students at the University of Manchester. Her academic research is mainly concerned with social epidemiology and the public health aspects of hearing loss, focusing on hearing health inequalities. She has an extensive background in hearing health in later life, health psychology, social epidemiology, health policy, and health services planning, and multi-year experience delivering innovative research on lifestyle factors in hearing loss. She will present the conceptual model of hearing health inequalities, which depicts modifiable factors for hearing loss from birth to older adulthood. She'll also present vicious cycles between socioeconomic inequalities and hearing health. We also have a medical student today, Marwan, who's in his second year at the moment. And he's also the education director for YoungAcademics Manchester. He's interested in pursuing teaching and research as well. So over to you.
Thank you very much, Asta. So just before we start, I just want to launch a poll here to see, and then we'll do another one at the end, just to see the general opinion on our topic. So I'll just launch it there now. And if everyone could take a minute just to fill it out. It's only 3 questions, so. We'll just give it another minute or so. Still 10 more participants to fill it out. Okay, just 10 more seconds. If you can please fill out the poll just so that we can, it's really useful for our data. Okay, so I'll just end the poll there. And now Dr. Dalia, if you can go ahead, if you could share screen.
Yeah, I'm going to share my screen. As I'm sharing my screen, would you like to explain the purpose, the aims of today's event?
Of course. So today we've just organized this talk for World Hearing Day. This is a day on the 3rd of March in which we're spreading awareness across the world. Really many different events are being held across the world, and ours is one of them. So we're very glad to be a part of this prestigious occasion. And it's essentially just to spread awareness about hearing and how essentially it has a huge, wide lasting implications, both socially and in the health context as well. And so hopefully our purpose today is just to help spread awareness, as well as to help you guys become more informed. So hopefully whenever you do come into practice, or if you're already a practicing practitioner, you could take these into consideration, hopefully in the future. So I'll now hand over to Dr. Dalia, who is a world-renowned researcher in this area.
Thank you very much. Thank you for this introduction. Welcome everyone to this event. I'm going to talk to you about an important part of our lives. I'm going to talk to you about hearing. And hearing is important because hearing connects us. We humans are made for relationship, and hearing, for those not born deaf and fluent in sign language, is central to the sharing of emotions and ideas and happenings. I'm Dr. Dalia Tsimpida, and I'm really passionate about research that transforms the lives of people with hearing difficulties. The 3rd of March, it's a year, marks the World Hearing Day, a day that is important for more than 460 million people with hearing loss around the world, and for those with whom they communicate. It is important to highlight that no matter the age of onset of hearing loss, when somebody loses their hearing, not only the ear function itself is affected, but also the related activities. For example, understanding speech during communication is reduced, and the participation of the individual in society is affected. People with hearing loss have limited employment opportunities, and there are many barriers in education, in attending social events, or receiving health services. This holistic and patient-centered approach will inform my presentation today, which has the title Hearing Loss in Adults, a Major Public Health Issue and a Challenge for the Medical Profession. I will present you today why do socioeconomic and lifestyle factors matter, and evidence I produced during my doctoral studies at the University of Manchester using the English longitudinal study of aging for the role of a socioeconomic position in terms of etiology, the early diagnosis of hearing loss, and mental health inequalities in those with a hearing loss. So hearing loss is far beyond a sensory impairment because it has many physical, social, cognitive, economic, and emotional consequences and affects the quality of life. It is the 3rd most common chronic health condition after high blood pressure and arthritis, and is the 1st leading cause of morbidity among adults 70 years old and older, and the 2nd leading cause among adults 50 to 69 years old. Today, hearing loss is a major global health challenge. It is estimated that affects the life of over 460 million people globally and those with whom they communicate. Unless action is taken, this number could cross 900 million by 2050. I and my colleagues proposed a novel theoretical framework supporting the argument that a substantial proportion of hearing loss in older adults is preventable by tackling the socioeconomic inequalities in hearing health. Now I will explain why a socioeconomic approach is crucial for planning sustainable models of hearing care. The unequal distribution of power, money, and resources in a society leads to social inequalities. As a result, some groups of people are more privileged than others, which creates injustice and disadvantage that influences life experiences and health outcomes. Some critical indicators of socioeconomic position include the educational status, occupation, and income. Hearing health inequalities is an emerging research area, and I and my colleagues recently proposed a definition saying that hearing health inequalities are the avoidable differences in people's hearing health across different social or population groups. The mechanisms by which these inequalities are generated remained unclear so far, and using critical interpretive synthesis methodology during my PhD, I examined the mechanisms to explain the relationship between socioeconomic inequalities and hearing health in a life course perspective through a conceptual model. This model provides a visual representation of the several modifiable factors of hearing loss in distinct life stages across the life course and their evolution over time, which is a new thinking in hearing and audiological research. Now I will explain this novel model and the modifiable factors in each developmental stage. First of all, children in childhood. Children born to parents from a lower socioeconomic background tend to experience more illness and injuries, and the antibiotic drugs used may affect the hearing health, especially in sick babies with a genetic predisposition. In turn, consequences of hearing loss in children can include the impairment in language skills and lower educational achievement compared to children with normal hearing. The lower educational status is also related to the lower health literacy, which is a common issue among people of a lower socioeconomic position. And that can explain why individuals of a lower socioeconomic position adopt an unhealthy lifestyle with higher levels of smoking and alcohol consumption, higher body mass index, and lower levels of physical activity, which are all risk factors for hearing loss. The lower educational level is a predictor of social inequality in later life, as limits the employment opportunities, relegating people to more poorly paid jobs. Furthermore, low-level manual jobs are those with a higher level of occupational noise exposure, and noise is a risk factor for hearing loss. Occupation and income may affect then access to hearing health services and hearing aids use due to financial barriers that affect the help-seeking behavior for hearing loss difficulties. These hearing health inequalities can affect the retirement status and income in older adulthood, as you can see in the fourth panel, as the inequalities affect the ability of people to continue working or to advance occupationally. Also, hearing loss affects communication in healthcare settings, and so affects the quality of care and the management of many other health conditions that are commonly comorbid with hearing loss. For example, cardiovascular disease, Alzheimer's and dementia, diabetes, chronic kidney disease, depression, and many other chronic health conditions that are usually comorbid with hearing loss in later life. As hearing health deteriorates, this lowers socioeconomic status further and results in a worsening cumulative hearing health over the life course. This is why I selected different colors of orange to see the cumulative factors across the life course and how the low socioeconomic position then affects hearing health, and this leads to a lower socioeconomic position again in a vicious cycle. This brings the life course approach in hearing health and can lead to the development of appropriate interventions and public health strategies that can have significant health policy and practice implications. This is a theoretical model, and during my PhD, I tried to verify the role of socioeconomic and lifestyle factors. So I presented the first study in audiology that brought a sociological perspective in audiological research. And I examined the association of objectively measured hearing loss with 4 different socioeconomic position indicators: education, occupation, income, and wealth. And they explored also the role of several modifiable factors such as tobacco consumption, body mass index, physical inactivity, and alcohol consumption above the low risk level guidelines, which is 14 units per week. So what we found is that those in a lower socioeconomic position were up to 2 times more likely to have hearing loss at the same age. And the adjusted odds ratio of hearing loss were higher for those with no qualifications versus those with a degree or higher education, those in routine or manual occupations versus those in managerial occupations, and those in the lowest versus the highest income and wealth quintiles. So vast inequalities across different socioeconomic position. And the study also showed that hearing loss among older adults is as strongly associated with socioeconomic and lifestyle factors as with core demographic factors such as age and gender. In simple words, this study revealed for the first time that age was not the most important risk factor for what is widely known as age-related hearing loss. The term age-related hearing loss is not an inclusive term to express the many hearing problems without a specific etiology in older age, and therefore I decided to coin and to introduce to the literature a new term, the term lifestyle-related hearing loss. Here, lifestyle refers to social practices and ways of living adopted by individuals that reflect a personal, group, and socioeconomic identities. In other words, there are many modifiable factors that affect the degree of hearing loss one may have in later life. So it's not inevitably the aging process, but there are many other factors that can be fully modifiable or partly modifiable. Let's now see the socioeconomic inequalities in diagnosis, which is also important for you as the doctors of the future. So in a recent study, we examined patterns of health pathways among older adults in England using hearing data of 8,529 participants aged 50 to 89 years old from the English longitudinal study of aging. This is a big data set, representative of the English older population in England. And we found that up to a third of older adults with hearing loss in England could be undetected and untreated. In that study, I found that although participants had objectively been identified as having hearing loss, moderate hearing loss over 35 decibels hearing level, they did not self-identify their own difficulties correctly, and the same person, the same people that had the hearing loss reported in the self-reported questionnaire that they had good, very good, or excellent hearing, despite the fact that the objective measurement showed that they had a disabling hearing loss. Significant predictors for this misreporting were female sex, so women did not recognize the hearing difficulties correctly, people with no educational qualifications, people working in routine or manual occupations responded that they have a good, very good or excellent hearing despite they had disabling hearing loss. Those with tobacco consumption and alcohol intake above the low risk level guidelines, and those with lacking moderate physical activity. So lots of socioeconomic and lifestyle factors affected the total misreporting. This lack of self-awareness of hearing loss is a problem for many people. And it is crucial that those with hearing loss are detected in a timely way, referred to ear specialists. So the early diagnosis takes place in primary care. And the GP, in the GP practices, the GPs refer people to secondary care for further audiological examination from ear specialists, so as to be given access to hearing aids which are provided for free in the UK. However, it is crucial that those with hearing loss are detected in a timely way, but we need to identify why people don't realize early that they have a hearing problem. The reason is that many people believe that hearing loss refers only to inability to hear sounds in terms of the intensity of a sound, how loud is a sound in decibels. However, this is not correct because hearing loss refers not only to the intensity of a sound, but also to the frequency of sound in hertz. The range of sounds of the average human speech can be represented in a banana-shaped region known as the speech banana. When you have a hearing loss of only certain frequencies, it is harder to detect yourself because the other frequencies that remain unaffected appear pure and clear. And this may lead you to the impression that your hearing is completely normal, which may lead to a wrong self-diagnosis. So many people think that the hearing loss is not too bad, and as hearing loss nearly always develops gradually, people don't see it as a dramatic health problem requiring urgent intervention. And they persevere with declining hearing for approximately 10 years before they seek help and take up a hearing aid. There is no national screening program for hearing loss, and those who are diagnosed are usually diagnosed by their own doctor. This is important for you because if the patient doesn't bring the matter up, the doctor might not ask about it. So you need to be aware of all these potential hearing difficulties and to be able to ask the right questions to the patients and to screen them in primary care in order to see if there is a reason for referral to secondary care. More research is needed to understand why so many people are undiagnosed, though I and my colleagues feel that making hearing loss part of a routine primary care examination among older adults would be really beneficial. Regarding now the socioeconomic inequalities in mental health, this is a huge issue as well. And my recent research findings provided robust evidence that the hearing loss directly causes depression, which differs according to socioeconomic position. A graded relationship between hearing loss and depression according to socioeconomic position was revealed, with those with hearing loss in the lowest wealth groups experiencing up to double the relative risk of depression compared to those in the highest wealth quintile. So people of the same age, if they belong in a lower socioeconomic position, have up to double the relative risk of depression. Therefore, the early detection of hearing loss by primary care professionals in routine assessments may not only promote better hearing health and opportunities for better communication, but also may prevent or delay the onset of depression in later life. So there is a clear need for establishing evidence-based programs for hearing screening, and this is underscored by the new National Study of Hearing in England, which we published recently, published in January in the International Journal of Audiology. And the study revealed that people in the north of England are more likely to have worse hearing, closer to 50 years old, than those with similar age profiles living in the south. This is linked to a history of socioeconomic and health disparities between the north and south part of the country. In this short talk, I presented my recent research findings for the role of socioeconomic position in terms of etiology, early diagnosis, and mental health inequalities in those with hearing loss. Hearing is an important part of our lives, and it is important to early diagnose any hearing difficulty so as to be able to enjoy life and be connected to the world. As a take-home message, I would like to highlight that hearing deterioration is a lifelong process. It is not an inevitable result of aging, as previously thought, and understanding this process is an essential step in addressing the burden of hearing loss and the management of related comorbidities in later life, such as cardiovascular disease, diabetes, chronic kidney disease, Alzheimer's and dementia, depression, and many other conditions that are connected due or in parallel to hearing loss in later life. Thank you very much for your time and your attention. I'm really glad and happy to answer any questions you may have now or at the end of the presentation. If you want to write in the chat box any question, I would be glad to take it and answer now or later.
Thank you very much, Dalia. That was really inspirational and eye-opening. I think we'll take questions at the end, hopefully. Okay. So at the end of both.
Okay.
So I'll just get my presentation up now.
Mm-hmm.
Okay, so hopefully now I'll just be broadening the perspective of hearing loss towards the greater public. You might think that, or some people may think that hearing loss is quite a niche thing. However, hopefully with the coming slides, you'll understand how it actually has huge implications on public health. So I'm just going to start off by reiterating the slide from Dalia. As we can see here, I'll hopefully be going into this list of things that hearing loss has a huge effect on. As we can see here, it has huge physical, social, cognitive, economic, and emotional consequences. And hopefully I'll be delving a bit further into these. It is the third most common chronic health condition, and these are huge names: high blood pressure and arthritis. So it's important, highlighting hearing loss's importance. So, and as we've said, that a third of over 50s with hearing loss could be undiagnosed. And that is the newspaper article that Dr. Dalia had showed. Okay. So the early detection of a decrease in hearing is quite important, as it hugely affects the clinical setting. Poor communication within the consultation could leave a patient quite confused about their condition, and it could also lead to them being unsure about the instructions that the healthcare professional has given them. as we can see here in this illustration, I'm sure this is a situation that we've all been put in before. And so you can just imagine the patient could also be afraid to ask any clarifying questions. And so it's important as health professionals to make sure that the patient has understood what we have said. So about going back to what Dr. Dalia has said about making sure you have detected if there is any hearing loss within the patient and how we can target that. This next figure here just displays how difficult it is for patients that are hard of hearing. So if we could just take a second to try and read this. And as you can see, reading that figure is quite hard. And so you can just imagine what it is like for people who are hard of hearing, especially in the clinical setting, whenever they are getting, different names of drugs and dosages, milligrams, micrograms. These are important details that may be missed out during the consultations, which could have like a huge effect on the patient, the quality of the care that the patient receives in the future. So this does raise the question towards us as clinical professionals. Are we being heard by all of our patients? Especially in the UK with quite an aging demographic. Hearing loss is a condition more common in the older ages, and so it is becoming more frequently come across in our clinics. It is not only crucial for the patient, but also crucial for us as medical professionals, as important communication is important for getting the symptoms and accurate diagnosis. So we need to really evaluate ourselves as professionals or future professionals, that are we really communicating effectively? Are we clear and concise with our patients, and are we using easily understood language? So it is really important for a doctor to really self-reflect. Here are more illustrations to show how difficult it is for the people that are hard of hearing. And so it was not surprising at all when Dr. Dalia had recently found that people that are hard of hearing and deaf are actually overall dissatisfied with the way the health providers communicate with them, and they do not have trust or confidence in health professionals. In a system where we value trust so highly with different legislation such as confidentiality, losing the patient trust and their confidence is a huge thing. And this can also lead to it translating in any other conditions that the patient is being treated for, such as their heart disease or whatever. And so it can not only affect them, it's not simply just the patient not being able to hear, it can also lead to a wider effect into their overall healthcare. Problems with communication can also lead to poor adherence with patients, especially in the older demographic, as I've just mentioned. Polypharmacy is quite a common thing. And so this leads to the double challenge of remembering and comprehending what the doctor has said, especially as I've mentioned before with the different difficult drug names that an elderly person could be prescribed on. And polypharmacy, just for clarification, is when a person is prescribed with many different drugs to combat many different conditions. So it does not only have huge health impacts on the patient, but also has huge impacts on society in general. As we can see, the economic impact of hearing loss can amount to about £150 million a year. Now, that is quite huge. And this illustration here that we can see at the bottom, it illustrates that the people with the small rucksacks are the people that are not hard of hearing, and the people with the large rucksacks are hard of hearing. And as we can see here, although the hard of hearing patients have more burden, they have less access to health services. And so this is quite a powerful illustration. As already mentioned, hearing can also be a huge driver of other health problems, for example, depression. And as we can see here, the purple bars are the patients who are hard of hearing compared with people who have normal hearing. And they can be up to 40 to 58% more likely to have depression. It is also quite sad to say that there's a graded relationship between the socioeconomic status and the likelihood of a person that's hard of hearing to have depression. And so this links back to the conceptual hearing health inequalities model that social inequalities could have a huge impact on people's health, especially when they're hard of hearing. In addition, hearing loss is not only linked with depression, but it also can be a huge signal for upcoming cardiovascular disease. It can also predispose to Alzheimer's and dementia, and also have even cognitive deficits upon the patients. They may have diabetes at 32% more likely for hospitalization, 43% more likely for chronic kidney disease, and 3 times more likely to fall. Of course, I've already mentioned depression, and unfortunately, it also has a higher mortality rate. So this online user commented that the biggest barrier to people with age-related, I'm assuming hearing loss, is their GPs. GPs have limited understanding of the associated problems that come with hearing loss. The attitude is, well, you can hear me okay. This is, I apologize, that's the customary accidental lecture slide skip. So this is quite poignant, and especially in our healthcare system in the UK, where achieving goals is quite an important thing. GPs are constantly aiming for 10-minute consultations to reduce the number of prescriptions. And so we sacrifice a lot of the quantity of care and the quantity of minutes that patients receive. However, we should not sacrifice the quality. And that is where our consultation skills learning within medical school comes in, where we should have a lot of patient-centeredness. And this can help really tackle the problems that are presented to us by hearing loss. So it's important to understand the magnitude of the problem in England and globally, as hearing loss affects both the functional ability that enables well-being in older age. As shown by the International Federation of Aging, and this is a statement of intent that they're trying to tackle this large public issue. The World Health Organization World Report on Hearing had actually emphasized that functional ability of older adults is not maximized unless individuals have good hearing. The report highlights that it is possible to have good hearing across the life course through integrated people-centered ear and hearing care. This position aligns with the UN Decade of Healthy Aging, which is from 2021 to 2030, which aims to maximize the functional abilities of older people through the delivery of person-centered integrated health and social care. This is again emphasizing the importance of patient-centered consultations and cooperation within a multidisciplinary team with age-friendly environments. So we're close to the wrap up, and these are just some key messages from the World Health Organization due to World Hearing Day, which is obviously the thing that's the event that's gathered us here today. And these key messages are that it is possible to have good hearing across the life course through ear and hearing care. Many common causes of hearing loss can be prevented, including hearing loss caused by exposure to loud sounds, such as at events or even listening through headphones. Safe listening can mitigate the risk of hearing loss associated with the recreational sound exposure. The World Health Organization also calls upon governments, industry partners, and civil society to raise awareness for and implement evidence-based standards that promote safe listening. This is something that Dr. Dalia has been actively taking a part in, and what has gathered us today. So the take-home message from me is, first of all, that hopefully I've highlighted how important hearing is. It has both physical, social, cognitive, economic, and emotional consequences, and hopefully that message has been conveyed. It is important for us to use our hearing to listen and ensure that we incorporate the patient-centeredness that we are constantly being taught in medical school. Following the patient narrative is an essential process to this aspect of this. Although the current generations of doctors have undergone this training, there is still a huge gap between teaching and application of this in the clinical setting. And so this is quite a large, it's quite poignant actually that there is still a huge gap. And so even though we are going through this training, it's important that we actually take the extra step in applying it whenever we are not being examined for OSCEs, because this is something that generally when we take the Hippocratic Oath, it's something that we do as our duty of care to the patient. This message is applicable to all health workers and not just medical students in the upcoming generation. The vision is to have a world which no person experiences hearing loss due to preventable causes, and those with unavoidable hearing loss can achieve their full potential through appropriate interventions, education, and empowerment. And that is the end of my slides. So thank you very much for listening, and I hope you enjoyed the presentation. We've now just got another poll just to see if the opinion has changed. However, before that, would you guys like to have any questions answered? If you could just place them in the chat if you would like. I think I'd like to read this message out actually that Hazel sent into. Okay, here we. Well, I'll read Hazel's message first. Good evening, everyone. Thank you very much for this event. I have hearing difficulties and wearing hearing aids for about 15 years, and it affects my social life as I usually feel afraid to interact with people because sometimes I feel embarrassed to ask them to repeat what they say, and most of the times I'm misheard, which makes the situation much worse for me. Thank you very much, Hazel, for sharing that with us. I'm hopefully like the steps that we're taking, such as today, can hopefully make the experience better for everyone in the future and even now within the clinical setting. Dalia, we do have a question here. What sorts of questions could you ask in consultations to gather information about hearing loss?
Yes, so you can ask a patient to indicate in a 5 Likert point scale when 1 indicates excellent and 5 indicates poor, so as to rate themselves if they have any difficulties. If they say 4 or 5, 1 is excellent, 2 is very good, 3 good, 4 is fair, and 5 is poor. So if they say 4 or 5, which means fair or poor, that means that they have a significant difficulty in their daily lives. And another question that may be important to realize whether they have an issue in specific frequencies is to ask them if they find it difficult to follow a conversation, if there is background noise, such as television, radio, or children playing. This is because all this noise, such as television, radio, and children, mask the low frequencies. So if a patient has a hearing loss in high frequencies, which usually is 35 decibels in a frequency of 3 kilohertz, so when they have difficulties to participate in conversation in background noise, you have an indication that they have moderate or worse hearing loss. So asking one of those 2 questions in a consultation will give you an indication of any hearing difficulty which may need further examination in primary or secondary care. There are some new developments in this area. So the World Health Organization has asked the governments to initiate some screening programs in primary care. But these 2 simple questions can be a good first step, a good start for self-reported hearing difficulties.
Thank you. And Corinne has just said, but you mentioned they think that they are all right with no issues. Is there a tool that we can use that is objective?
There is the case that they may answer that they have a good, very good, or excellent hearing in the first question in the 5-point Likert scale. But if they answer yes in the question whether they find it difficult to follow a conversation if there is a background noise, such as a television, radio, or children playing, this shows that they indeed have a hearing problem. So this will give you an idea that they may need a referral or further examination. Regarding the tool, the objective measure I used in the English longitudinal study of aging is called a hearing screener. Is a screening tool that is used by several GP practices. But I guess that if there is a national program, the government will decide on a specific tool to be used from all primary care professionals.
Thank you very much. Any other questions? Komal said, do you recommend medical students to learn basic sign language?
That could be useful. To be honest, I attended classes and I'm professionally certified in Greek Sign Language. So I studied for 5 years in Greece and learned the sign language in an advanced level. And that also motivated me to seek further and research further the many barriers that people face during the use or the access to health services. So during my courses, I met many people. I became a member of a deaf community. This is a different aspect of hearing difficulties because people who communicate in sign language consider themselves as members of a special community and different culture. So it would be nice to get some awareness, to get familiarized, but there were different categories of people with hearing loss. There are people that were born with hearing loss and probably communicate in sign language, but there is also a huge category of people with acquired hearing loss that have developed hearing difficulties across their life course. So at the moment, for example, we have just to a number to understand 100,000 people who communicate in sign language and 12 million people with acquired hearing loss. So it's useful so as to be able to communicate with this cultural minority who communicates in sign language, but also the awareness of hearing difficulties needs to be applied to all categories, either acquired hearing loss or many other subcategories of people with hearing difficulties.
Thank you very much. And Sama has asked, how is the work-life balance within the ENT specialty?
I think I'm not appropriate to answer that because I'm not ENT, I'm a psychologist by background. So whoever has any idea could offer any opinion.
Yeah, if anyone in the chat wants to reply, but I don't think we're the best. Komal has just asked, do adverse childhood experiences affect hearing loss?
Yes, as depicted in the model of hearing health inequalities, adverse childhood experience may affect the access to education, which then may affect income. Lower level manual jobs are those with exposure to excessive noise, which is again a risk factor for hearing loss. So there are so many factors that if somebody is in a lower socioeconomic position early in life, has a likelihood to develop during the life course hearing difficulties.
Thank you very much, Dr. Dalia. I'm just aware that 2 people have left, so I just want to make sure we get the poll in with everyone present before everyone leaves. So we're going to have another poll just to see whether the opinion has changed. So it's the same questions. I'm going to launch it now. And if you could just fill this poll out as well, please, so we can know if our talk has had any effect or any changing on your opinions. And also make sure you do not leave because the certificate will be emailed out with the feedback form, which will be placed in the chat. So make sure that you fill out the feedback form so you can get the certificates. While the poll is going, Hazel has asked how to overcome hearing difficulties with masks wearing, especially if I rely on lip reading. It's a good question.
Yeah, this is a really challenging, and I guess that many people with hearing difficulties are struggling and realized during the pandemic that they had hearing difficulties because they realized how much they rely on lip reading. So I'm afraid that there is no way to overcome the difficulties, but there is a way to be honest and communicate your needs, and if possible to remove masks and keep some distance so as to be able to keep reading lips. I think that in some occasions there may be some understanding, so as if you ask in a service or somewhere you need to ask and to explain that you need to read lips, I think that the person will understand, because it's a two-way communication. And the most important thing in communication is to clearly express your needs. This is the only thing I could advise. It's very challenging though.
Mm-hmm. I think even when I was in my clinical placements, actually every patient that I'd seen had hearing loss had already been used to saying, oh, could you speak a bit louder? I have hearing, before I'd even started the consultation. So yeah, I think stating your needs could be quite effective. Oops. Okay. If you could just, 15 people haven't filled out the poll, so if you could just do that real quick before we end. And then if Asta, if you're present, do you mind putting the feedback form into the chat, please?
Yeah, I'll just do that. So once you fill in the feedback forms, you'll have the certificates available at the end. And I'm also putting a second link just to keep updated with the Young Academic Society in general.
Yeah, that's perfect.
And yes, thank you very much. Are there any other questions for Marwan and Dalia before we end? It doesn't seem like we'll have any more questions now. I'll continue ending the event now. So yes, thank you very much everyone for coming today. And for hearing our speakers this evening. So thank you, Dalia, thank you, Marwan. Thank you for putting this together for us. It really does make you think about how much more we can make healthcare accessible for those hard of hearing, especially since there seems to be a much higher prevalence than we might think, and it also might not be as immediately obvious. And it's wonderful to have someone so world-renowned and passionate in the field of audiology and public health, like Dalia, to give this talk for us today. She's also our teaching supervisor for the series of talks, so it's lovely to have you on board. I'd also like to thank the Young Academics Committee, Komal, Asta, Ryder, Elaine. Thank you for organizing the talk and promoting it. Thank you very much, Marwan, for giving us this wonderful talk alongside Dalia. And also thank you very much to the participants. I hope you found this talk incredibly useful and that you've learned something new. I definitely have. I'd like to remind you that if you could please fill in the feedback form that we'll be sending out afterwards. It won't take you long at all. Along with the feedback form will be your certificates, as Marwan said, as well as the recording, the slides, and links for future opportunities. And keep an eye out on our social media for any changes, because we post all of our activities and new opportunities and new talks there. Thank you very much, and I hope you have a wonderful evening.
Thank you, Casey.
Thank you.
So yeah, and the feedback form is right there in the chat just for you guys. Make sure you don't forget to do it for your certificate.
Bye everyone, thank you very much.
Is there